I think for this part, we invited Professor Brian Badgwell and as a discussant. And Professor Brian Badgwell actually is a professor of surgical oncology from the MD Anderson's Cancer Center in the United States. And he also the session head for the Department of Gastric and Peritoneal and Surgical Oncology. And Brian, I'll pass the time to you now, Brian.
Okay, thank you, Jimmy, for the introduction and the invitation. It's an honor to be here. And my comments will be brief. I mean, what am I going to add in addition to Dr. Glehen's expert opinion? And, you know, it's clear he's laid the groundwork for the process to establish HIPEC as a standard of care in gastric cancer. You know, the interest in peritoneal therapy for gastric cancer in the US is impressive. You know, it's not in the top 10 malignancies for us, but, you know, at every major surgical society meeting we have, it's prominently shown. And Dr. Glehen was even invited last year to the American College of Surgeons for that. The reason is in the US, for our patients that have no imaging evidence of disease, that look resectable, that we see in clinic, that we perform a laparoscopy on, 30% will have peritoneal disease, 20% carcinomatosis, and 10% positive cytology. Even then, all of our patients are treated with preoperative therapy. And after surgery, 50% will recur in the peritoneum. And so, you know, it's crushing. And so if we're going to improve survival, we are going to have to address the peritoneum. With that in mind, you know, it's notable that the only completed randomized controlled trial of HIPEC for gastric cancer was from 2011 and the Chinese study. You know, 40% of the world's gastric cancer is in China, and a trial with 34 patients in each arm is very small. And that still exists today, as far as I know, the only completed randomized trial for HIPEC in gastric cancer in the world. And really what we all want to know, I think, is we want HIPEC compared to the clear standard of care. And I think our medical oncologist from the first talk will agree with this, and that's systemic chemotherapy. You know, we had an attempted trial from the NIH in the US, the GEMSA trial. It was embarrassing. That only accrued 16 patients out of a planned 136 patients. The study was comparing cytoreduction in HIPEC to systemic chemo alone. This failure shows that it is exceedingly difficult to accrue patients to a trial with a non-surgical arm. The lines are being drawn and the trenches are being created already in this disease site. You know, even in the GastroPEC trial, as Dr. Glehen noted, with 2 surgical arms, the trial closed early, primarily doomed by a 56% progressive disease rate. And so you always have to calculate that in your trials because patients will progress on systemic chemotherapy. You know, and I think we all want to know, we just have to prove that a cure is possible for HIPEC. I think I want to mention briefly the Periscope 2 trial from the Netherlands. And that's for gastric cancer patients with a PCI less than 7 or positive cytology only and no disease progression during systemic chemo. So they're going to get out that 56% progressive disease rate. And so they're going to be randomized to HIPEC or systemic chemo alone. They're going to use a combination of oxaliplatin and docetaxel as presented in the recently published Periscope 1 trial that was in the British Journal of Surgery in October. But I think clinical trials are really important here because serious adverse events were noted in 70% of the patients in that Periscope 1 trial. They had a 16% reoperation rate and an 8% treatment-related mortality. Now, we do all anxiously await the GastroChip study and the potential necessity to perform HIPEC on all our gastrectomies. 90% of my practice is a T3 or a T4 or a node-positive gastric cancer. And so that could be a real practice-changing trial for us in the US. And I also think it's reportable that the complications aren't increased with HIPEC. I mean, I think that'll reassure other centers to pursue randomized trials of HIPEC. So that is really important data, and I hope to see that soon. So just to conclude, I hope all the attendees were inspired like I have been from the various speakers that we've had so far. I want to be brief because I know we want to hear about HIPEC. But you know, we also need to incorporate novel combination approaches with targeted and immunotherapy. And I think our medical oncologist that started the session showed that. We can't leave that behind or we will get left behind. And then just lastly, I do want to invite everyone to the International Gastric Cancer Congress in 2022 to Houston. We had to push it back a year, but that's going to be March 6th to 9th. And I hope to see many of y'all in Houston. So thank you again for the invitation.
Thank you, Brian, for the summary. And I think, yeah, you emphasize that the importance of clinical trials, I mean, in this setting. Thank you, Brian. And I think I just have one question for Professor Glehen. I think it's also from the audience is what's the extent of peritoneectomy, especially you are talking complete cyto reduction is very important. And for people who have low PCI, people with gastric cancer with PCI less than 6, do you always have to do a total peritoneectomy for those cases?
In my practice in peritoneal metastasis from digestive cancer, I'm always perform peritoneectomy according to the location of the peritoneal disease. So when you have a limited peritoneal PCI, of course, you will have a limited peritoneal peritoneectomy. So I'm not performing systematic peritoneectomy of some area that were not involved. It's perhaps more and more difficult with the development of the neoadjuvant intraperitoneal chemotherapy, especially with the HIPEC. I have more problem with this kind of patients that became resectable. The peritoneum was involved. It looks as a scar. Should you remove the peritoneum that apparently responds, you have to find, I think, the good balance. And of course, when you will combine your peritoneectomy, your HIPEC, to usually a total gastrectomy, you have to be very cautious about the extent of your peritoneectomy. But usually with a PCI less than 7, it's reasonable. And I saw another question I will answer very quickly regarding the anastomosis. As I am performing closed procedures, of course, I am using my anastomosis before the HIPEC. And I did not see so many anastomosis recurrence. So my advice, especially when you are doing a gastrectomy, is to perform your anastomosis before and not after HIPEC, because you will perform anastomosis on tissue with edema, and it's not so easy. And I think you increase the risk of a link before the recurrence.
Olivier, can you comment for ovary? Ovary, did you resect ovary, even they are not affected, or did you not resect them?
Usually, yes, but for some very young patients, I discuss this very extensively. And usually, in this case, I systematically refer the patients with a specialist of reproduction to discuss all the possibility. And but usually, yes, regarding the high rate of ovarian recurrence.
Thank you.
Okay. Thanks, Professor Glehen.